in very broad strokes, what are the principles of treatment? How do we approach multiple myeloma? In these precursor or precancerous or asymptomatic myeloma state, the standard of care is still active surveillance. Like for patients who have MGUS or smoldering myeloma, we actively monitor in clinic and we refrain from giving any treatment. Now, suffice to say, there is a lot of research going on in the smoldering myeloma phase in which we are trying to see whether treating a high-risk population early can have any better outcomes. But again, we do not have conclusive evidence yet, or that's an active area of research. It's very important to discuss with the patient, and we often do this in clinic, that we set the expectation that multiple myeloma is like an incurable disease at this point, and we often need some kind of therapy at most times for a patient for disease control. So the way we approach a patient is initially we see them in clinic. There are a lot of factors we consider, but one of the primary factors we consider is, are they eligible for transplant or not? Because if they're eligible for transplant, they usually follow one pathway of treatment, as opposed to if they're not eligible for transplant, they follow a different pathway of treatment, as you can see here. A patient who comes in, if they're eligible for transplant, receives a first series of treatment called an induction therapy, and this is followed by consolidation. What consolidation means is that we take the good response that is obtained by the induction and you consolidate or you cement it with a stem cell transplant, hoping that that good response will stay for much longer. And to make sure that good response stays for much longer, we put patients on what we call maintenance therapy. So again, starting off with induction, consolidate with stem cell transplant, and on long-term maintenance therapy until and if there is disease progression. And at each disease progression, which is indicated as relapse 1, 2, 3, 4, and refractory disease, we consider many different factors into selecting the best treatment possible. If someone's considered not transplant eligible, we often give one course of treatment followed by a continuous therapy, and then we address when the patient eventually relapses. So again, this is a very simplified approach to how we treat patients with newly diagnosed myeloma. Again, after a detailed assessment whether the patient is a transplant candidate or not, the induction therapy usually consists of a 3-drug or a 4-drug regimen called a triplet or quadruplet therapy. There are many, many nuances that go into a decision of whether a triplet or a quadruplet should be used, and the nuances of what kind of maintenance should be used. That's beyond the scope of today's talk. But just to give you an idea, we start with a 3 or 4-drug regimen, give a few cycles, harvest stem cells, and then do stem cell transplant if the patient's having a really good response. In another approach, you can give induction therapy a little bit longer and wait for a delayed approach to stem cell transplant. Eventually, you want to consolidate that good response you got out of transplant with what we call a maintenance therapy with either 1 agent or 2 agents. So that's one pathway we follow for patients who are transplant candidates. For a lot of patients who are not, unfortunately, candidates for transplant, we do induce them with, again, a 3-drug regimen, but sometimes we refrain to 2-drug regimens if we think they cannot tolerate it. And this is continued often until disease progression. At the time of disease progression, there's a lot of factors we consider, like their performance status, meaning how can you function with your activities of daily living and how well you can take care of yourself at that time, the age, if there's any cardiac or renal or neurologic comorbidity that they have, disease factors, meaning are they high risk or standard risk, all the other exposures to the medications we have given them before, what was the duration of the initial response that we gave, and then also a lot based on patient preference. We have patients coming and saying that we don't want, sequential IV treatments. Can they go on pills? Their access to like an institution that has access to all these medications, and also logistics of transportation. So a lot of factors go into how we decide to treat relapsed myeloma. A very brief overview of stem cell transplant. Stem cell transplant is usually done after that initial set of treatment called induction therapy. Stem cells are removed, and that removal process is called apheresis or harvesting from either the blood or the bone marrow. These harvested stem cells are concentrated, they're frozen, they're preserved, and the patient gets a high-dose chemotherapy to destroy any remaining myeloma cells in their bone marrow. And these stem cells, the patient's own stem cells, are reinfused back to the patients, where they will repopulate the bone marrow and they'll hopefully grow back as healthy new cells. So this is, a very simplified overview of how a stem cell transplant looks like. This is a table that shows, truly how the field of myeloma has changed in the past many, many years. all these columns show different classes of medications that we use to treat a multiple myeloma. And as you see, there are at least 10 different classes of medications. There are 20 different agents that we can use. I have grayed out some medications which have recently lost their FDA approval, and the italicized ones are those who don't have active FDA approvals yet. But these are all available at clinical trials in many, many centers. So it truly is an embarrassment of riches. However, we're still a long way to go from having like a very strong and potential cure for myeloma at this time. But I just wanted patients to have this idea that this is the arsenal of treatments that we have at our disposal to help you.